Hello, hi, welcome back from your break. We're ready to start our second and last session of the afternoon. I would like to present to you Ana Patricia Ortiz, Dr. Ana Patricia Ortiz. She's the Associate Professor of Epidemiology at the University of Puerto Rico Medical Science Campus. She's going to provide us the scientist perspective of how to report a balanced perspective in your news stories. And after her presentation, we're going to hear from Gary Schwitzer to provide the journalistic perspective.
Hi, good afternoon to you all. We have a lot of information to cover today, so I'm going to go ahead and start with any additional introductions. Can you hear me well? Yes? Okay. So basically, this is an outline of our presentation for today. We're going to be covering an introduction of what is cancer screening, a basic definition, an overview of clinical trials, and specifically of cancer screening trials, methodological aspects of cancer screening trials, potential biases that we can encounter in this type of research studies, and also we're going to end our presentation talking about a specific example of breast cancer, the current recommendations in terms of screening, and potential harms and benefits of these kinds of interventions. So what is cancer screening? As you may know, some types of cancer can be found before they can cause symptoms, and checking for cancer or conditions that may lead to cancer in people who have no symptoms is basically called screening. Screening can help doctors find and treat some types of cancers early. Generally, cancer treatment is more effective when the disease is found early on. Not all types of cancer have screening tests, and some tests are only for people with specific genetic tests. I want to highlight in this diagram the three kinds of prevention that we usually work with in epidemiology and clinical sciences. You have the natural course of disease, where you have no disease, this is normal people, a preclinical phase, and then you have a clinical phase that leads to a particular health outcome. When we talk about primary prevention, we're talking about interventions where we want to remove causes of disease in normal individuals so we can prevent the occurrence of disease. When we talk about secondary prevention, we are talking about doing interventions such as screening, where we can detect a disease early, usually on the preclinical phase before any symptoms arise, where we can actually do an intervention that can have a positive impact in the prevention of the negative health outcomes that a disease may have. So when you do a particular screening test, you're going to have an apparently well population, where you're going to have combination of different kinds of individuals. You're going to have negative people, those that are negative on the test, and that are actually negative. Those that are positive on the test have no disease, and those that are positive on the test, but the disease is actually present. All these people that result chose to be negative are going to be assumed to be disease-free, and no additional follow-up is going to be done on them. But then you're going to have people that are true positives that actually have the disease, and people also that may be false positives. So they're going to be shown positive through the test, but they actually might not have the disease. But the important part at this point is that people that test positive on a screening test are going to be brought back for future additional testing and diagnostic procedures and so on. So when we talk about cancer care, we want to make sure that we realize and differentiate what we know, what we don't know, and what we believe. And this is very important when we're talking about screening tests, because we know some things about screening tests. There's some things that we don't know in terms of their impact and benefit in terms of public health. And there's some other things that we believe about them, but they're not necessarily true. And that's why we need to practice evidence-based medicine and evidence-based public health when we take decisions about screening based on what we know from clinical trials and research studies that have actually shown the benefits and even potential harms of these interventions. So now I want to talk a little bit about clinical trials. And basically, clinical trials are research studies involving people where we try to answer scientific questions and find better ways to prevent, diagnose, and treat disease. A properly planned and executed clinical trial is a powerful experimental technique for assessing the efficacy of an intervention. And basically how it works is this way. When we have an experimental randomized study, we have a population where we're going to do a randomization and divide randomly individuals into those that are going to receive an intervention and those that are not going to receive an intervention. And that is different from observational epidemiology, because basically in observational epidemiology, the word is saying that we're just observing what is happening on a population, and we're trying to understand the association between an exposure and an outcome by observing exposure and outcomes in a population. But in randomized clinical trials, we are basically experimenting with the people and deciding which people are going to be going to the experimental group and which people are going to be going to the control group. So we are deciding what's the exposure. In this case, that we're talking about screening trials. We decide which people are going to get the screening intervention and which people are not going to receive that intervention, and then follow them through time to see what is the outcome of both the group that was allocated to the intervention and which was the group that wasn't. So why are these clinical trials important? Because they're basically the gold standard in terms of determining the efficacy of the interventions that we're trying to test, in terms of how good they are and what can be their positive impact in the population. So there are different kinds of clinical trials. These include treatment trials, where we're trying to understand the efficacy of drugs and particular medications that we want to test in terms of their benefit to people that are sick. Prevention trials. Also diagnostic trials, where we want to do the same probably with, for example, diagnostic procedures or interventions. And also trials that want to understand quality of life and supportive care of individuals. But we're going to be focusing today on early detection and screening trials, where basically we want to determine the efficacy of these screening interventions that we're trying to test in the population. So when we're designing a cancer screening intervention, we first have to we are assuming that this screening intervention can lead to early cancer detection, which can lead to decreased cancer burden in the population. And if we cannot prove that actually a screening intervention is going to have that impact, then we cannot really say that it's going to be useful to apply it to the population. So this reviews what we already mentioned in terms of the natural history of disease, but basically you're going to have the different phases include a preclinical phase where you have a biologic onset of disease, and then some symptoms can develop until you arrive to a clinical phase where you can actually do a diagnosis and receive therapy, and a particular outcome is going to result from those interventions. Basically, when we talk about screening, we're talking about doing a test where we can detect a disease early on, probably before the onset of symptoms, where we are still in the preclinical phase of disease. And being able to detect disease at that point is going to help us have an impact in terms of the development of negative outcomes of the disease, for example, what will be a mortality from the disease. So it's important to highlight that most cancers first go through a detectable preclinical phase where screening would not work if there was no clinical phase. In the absence of intervention, most cancer in a preclinical phase will progress to a clinical phase, but there will be no need for screening if cases will not progress to advanced disease. So this is the point where we want to be able to apply the screening intervention. An intervention is available for the detected cancer, and that the intervention can be more effective if the disease is detected at an earlier stage is another assumption of cancer screening. And we have to highlight that there is a critical point in the natural history of disease before which treatment will benefit a person more than if he or she is treated after that point. And it is at that critical point when we want to be able to identify this individual through screening. For example, in breast cancer, it is better to identify a person before this cancer spreads to the lymph nodes or before this cancer invades other organs. So cancer screening interventions are not automatically beneficial, and that is something very important for us to recognize. Not all screening tests are helpful, and most have risks or harms associated to screening that we have to recognize. And we have to be able to balance out the risks and benefits of doing this early detection. Decisions about screening, therefore, are not always easy. It is important to know the risk of the test and whether it has been proven to reduce the risk of dying from cancer. And the way we prove this is basically through these clinical trials based on this screening test. It is important to carefully and rigorously evaluate a screening exam before it is introduced to the population, because if we go ahead and jump to conclusions without that sufficient evidence, we might be, for example, expending too much money on a test that is not really going to have an impact on the population, or we may also, for example, be inducing some harm in the population through a screening test that maybe doesn't have the benefits that we thought or that we believed it might have. And it is very important that the benefits must outweigh the harms in any kind of public health intervention we do at the population level. So what are some potential harms of cancer screening trials? Overdiagnosis, false positive screening exams, complications of screening tests, complications of diagnostic procedures to evaluate a positive screening test. Like I mentioned earlier, after a person is screened and shows to be potentially a positive case, we actually do have to do some other diagnostic tests to corroborate this result. For example, in breast cancer, we could do a mammography, but then we cannot be definitive about maybe a particular mass that is found on the breast through that test. So the doctor has to do other invasive procedures, for example, a biopsy, and there might be some complications of those additional testing to corroborate that diagnosis. Also, complications of treatment procedures for cancer patients, adverse medical events, and even death can result from cancer screening in terms of potential harms. Now I want to highlight some methodological aspects in terms of cancer screening trials. And a vital concept in this area is the concept of randomization. Randomization is going to eliminate potential confounding in terms of baseline characteristics. And maybe confounding is a term that might be new for many of you, so let me explain it briefly. In epidemiology, we always are trying to understand how an exposure is associated with an outcome. In this case, we have an intervention that is going to be a screening, and we want to understand what is going to be the impact of screening in, let's say, preventing cancer death as an outcome. Well, confounders are third variables that are actually associated to the exposure, in this case screening, and are also associated with the outcome, in this case death, that if you don't control for them in the design of your study, are going to actually confound or confuse the real association that you expect to observe between the exposure and the outcome. So for example, age is a typical confounder in epidemiological studies, and it's a variable that you want to control, in this case through randomization, to make sure that people in both study arms, those that are going to the intervention and those that are going to become the control group, you want that age is a variable that is similar among those groups. So at the end, let's say that you see more death in the intervention group, but maybe it was that the intervention group was the group that anyway was an older age group. So then maybe at the end what occurred was that you saw more death in that group, but it was because they were older than the people in the control group. So by controlling for age at baseline, you can feel more comfortable that at the end, if you conclude that the intervention in some way, let's say in this case that it was harmful and increased death, it wasn't because of age differences in the groups. It was actually because the intervention in this case was harmful for the population. So randomization is a process that is going to help us eliminate confounding of different potential variables that might confound our results at baseline when we are designing the study. Another real concept of screening trials is the fact that we can study primary and secondary outcomes. For example, a primary outcome can be mortality, but other secondary outcomes can be studied also in the process, and trying to understand, since you are designing the study, what is going to be your primary outcome and your secondary outcomes that you want to evaluate through that study is going to be important. It's also going to be important the way you recruit your study population in a way that you make sure that your results at the end are going to be representative of the population that you want to be able to make conclusions about. So here, for example, I have a diagram of the process of randomization. Here, for example, you have an eligible population which you're going to randomize make sure that you have comparable individuals in both the intervention group, in this case the ones that are going to be screened, and the non-intervention group or the control group, those that are not going to be screened. And after the randomization and the allocation of people in the groups, you want to follow them through time to see actually what proportion of them died from the disease and what proportion didn't die from the disease in both the intervention and the control group. And at the end, what you want to be able to see is that if actually the intervention is beneficial, you're going to see reduced death in the intervention group as compared to the non-intervention group. So randomization is the basis for testing statistical significance between these groups, and like I mentioned, it's going to guarantee equal allocation of baseline characteristics. But I want to highlight that a good thing about confounding variables is that if for some reason your randomization didn't permit you to have at the end comparable group of individuals, in the statistical analysis you can actually control for these variables also, which is actually different from bias, because once your study is biased in terms of the design, if you didn't design it well, when you're doing the statistical analysis later on, you cannot really control for bias introduced earlier on in the study. So here I want to bring the concepts of internal validity and external validity, and this refers to the fact of how representative are your results in terms of your conclusions from your study. If you're through randomization, you can achieve good internal validity of your study, and basically that involves that whatever are your conclusions from the study actually apply to the people who participated in the study. But that is different from the external validity of your study, which refers to how you can apply your results to the reference population from where you recruited study individuals. So being able to also recruit a study population that is representative of the reference population is also going to be important for you to be able to make conclusions of not only how well your screening test is for people who participated in the study, but for people in the general population in general. So also something important when we're designing a cancer screening trial is the fact of duration of follow-up. You want to make sure when you're designing a study that after you do the intervention, that you follow individuals for a long enough time so you can actually see the outcome that you're studying for. Because if your outcome in a study is mortality, probably you cannot follow the people just for 1 year to be able to see the outcome occur. So for example, you have to make sure that it is long enough to allow for time for mortality reduction if that is your outcome. And for example, a couple of clinical cancer screening trials in the area of lung cancer and breast cancer have followed up their participants for more than 7 years to make sure that they have enough time to see the outcomes of interest. It's also going to be important that you have a good sample size for your study in order to ensure the validity of the trial. And when you do these sample size calculations, which have to be consulted with the biostatistician of the study pretty much, you have to consider what are the hypothesized mortality reduction that you expect, the expected compliance in both arms, the intervention and the control group, the number of screening rounds, and also the length of follow-up. And that is important because you have to take all those into consideration when you do your sample size calculations. So when you're measuring outcomes, like I mentioned earlier, you can have a primary outcome, like cancer-specific mortality or all-cause mortality, and you may want to go ahead and have also secondary outcomes that you can measure through your clinical trial. And these include, for example, to be able to understand the sensitivity and the specificity of the screening test, sensitivity referring to the proportion of 6 persons that are actually classified as positive through the test, and specificity as the proportion of healthy persons that are actually classified as negative through the test. And both of these, sensitivity and specificity of a screening intervention, are going to be very important. Also, other secondary outcomes may include the harms and the quality of life of participants or of the people that receive the intervention versus those that participate in the control group. Another important concept in terms of a scientist's perspective, in terms of clinical screening trials, is the concept of number needed to screen. And this involves, basically this is a summary population measure used in assessing the effectiveness of screening. And it is defined as the number of people who need to be screened in order to prevent one additional death due to cancer. This calculation takes into account both the characteristics of the screening test and the effectiveness of the treatments available. The higher the number needed to screen, the more people who must be screened in order to impact one person's lifespan. I don't have too much time, so I'm just going to highlight these are a couple of concepts that are operational measures that you can see in your slides in terms of cancer screening programs and their effectiveness. Things that we like to consider, for example, the cost of the program. And these are a couple of outcome measures that we like to study when we're evaluating screening programs, and these include if they have an impact in terms of reduction of mortality, increasing the percent of cases detected at earlier stages, reduction of complications, and improvement of quality of life, among others. I want to quickly go to potential biases that you can find in screening clinical trials, and these include selection biases, lead time bias, and overdiagnosis bias. Basically, when you do a screening program, there's going to be 3 different outcomes that you can see. You do an earlier diagnosis through screening, and you can follow people until they have their usual time of death. Or you can do earlier diagnosis and actually have an impact and have a delayed death of that person as a result of screening. But also you can do the screening and maybe no death from screen cancer occurred. So these are 3 different scenarios that you can see. When you have length bias, basically you're having a systematic error from detecting disease with a long latency or preclinical period. And basically what happened is that patients with screen detected cancer survive longer, not really because the screening is having an impact in that area, but because the screening cancers are more indolent, or maybe they were cancers that they were not going to progress so fast. So basically you're seeing a longer latency period, but it's actually not real. It's occurring as a result that you detected cancers that were more indolent. You may also have in these kinds of studies referral or volunteer bias, and this is a systematic error from detecting disease in persons who have a propensity to seek healthcare. So probably volunteers that are participating in these studies are people that are healthier or are more likely to comply in terms of clinical recommendations. You may also have in these kinds of trials what is known as lead time bias, which is a systematic error of apparent increased survival from detecting disease in an earlier stage. So you may have 2 kinds of individuals. Let's say here in the intervention arm and here in the control group, you may have 2 people that are sick. Here you did an earlier diagnosis through screening, and people die at this point. Here you didn't do screening and people die anyway at the same point in time. So basically this is a kind of bias that you think people are living longer, but it's not that they're living longer, it's actually that you're detecting them earlier that would have occurred without screening. And also overdiagnosis bias is the recognition that screening may detect a condition that is not a lethal cancer or may not affect a person's life. And we are actually diagnosing maybe some tumors that may actually not progress into a malignant cancer that may kill that person. And I want to end my presentation. Those were basically basic concepts in our area of cancer clinical trials and cancer screening trials. But I want to end the concepts that I have mentioned with a breast cancer example. So basically there's 2 tests commonly used for screening for breast cancer at this point, the mammogram and the clinical breast exam. So the mammogram is basically an X-ray of the breast, a test that may find tumors that are too small to feel. The ability of a mammogram to find breast cancer may depend on different factors such as the size of the tumor, the density of the breast tissue, and the skill of the radiologist. A mammogram is less likely to find breast tumors in women younger than 50 years of age, and that is one of the reasons why there have been so much debate in terms of the age when to start breast cancer screening. And this is the reason for this is basically because younger women have a dense breast tissue, and it's more difficult for this kind of test to differentiate mass versus actually the normal breast tissue of that woman. The clinical breast exam is an exam of the breast performed by the doctor or health professional. Well, the doctor is going to feel the breast and under the arms for lumps or anything else that seems unusual. So what are the current known risks of these kinds of breast cancer screening tests that have been observed basically through these clinical trials that we have been doing across time? For example, finding breast cancer may not improve health or help a woman live longer. So it may, but maybe it may not, depending on the woman. Screening may not help you if you have a fast-growing breast cancer or if it has already spread to other places in your body. Some breast cancers found on a screening mammogram may never cause symptoms or become life-threatening, which could be an example of overdiagnosis, as we mentioned earlier. And currently, it is not possible to be sure which breast cancers found in screening will cause symptoms and which ones will not. We may also have, through screening, we may also identify what are actually false negatives. So false negatives are through screening tests may result in, screening test results may appear to be normal even though breast cancer is present, and this is considered a false negative. So a woman will receive a false negative test result, or one that shows there is no cancer when there really is a cancer, may delay seeking medical care even if she has symptoms. So this is an example when becoming a false negative of one of these tests can be negative for yourself. We know that 1 in 5 cancers may be missed by mammography. False negatives occur more often in younger women than in older women, and this is also one of the reasons why recommendations focus more on older women unless they have a genetic history of the disease. And the chance of false negative is also affected by other characteristics of the woman and the skill of the radiologist. You may also have false positives, which are people that even they show to be positive through the screening test, but they are actually not positive, but given that they tested positive, they're going to be submitted to additional testing interventions. False positive tests, when they occur, can cause anxiety, and is usually followed by more tests such as biopsy, which can also have risks. Most abnormal test results turn out not to be cancers, and this is actually more common also on younger women with previous breast biopsies, those with family history of cancer, and other factors also influence this kind of outcome. In terms of other risks that can be seen through breast cancer, is the fact that mammograms expose the breast tissue to radiation, and we know that radiation is going to be a risk factor for breast cancer. The risk of developing breast cancer from radiation exposure, such as screening mammograms or x-rays, is greater with higher doses of radiation and in younger women also. For women older than 40 years, the benefits of an annual screening mammogram may be greater than the risk of radiation exposure, so that is why we still recommend this type of screening, despite the radiation, but we have to be careful also and recognize that kind of risk. It is also important to highlight that the risks and benefits of screening may be different for different people. For example, the benefits of breast cancer screening may vary among age groups. In women who have a life expectancy of 5 years or less, finding and treating early-stage breast cancer may reduce their quality of life without helping them live longer. So what will be the use of screening that kind of person? In women older than 65 years, the results of a screening test may lead to more diagnostic tests and anxiety while waiting for the test results. Also, the breast cancers found are usually not life-threatening. Also, giving us information that maybe we shouldn't be doing screening on women of those ages and older. It has not been shown that the woman benefit from starting mammography at younger than 40 years, and this is also why evidence supports right now not screening among younger age groups. I know I'm out of time, but I want to go ahead and highlight that there's a couple of resources that are going to be useful when you're trying to understand. At the end of the day, what we're trying to do is evidence-based medicine and evidence-based interventions, and we have to recognize that there's resources out there that actually summarize that information for us and help us understand what is the current evidence of the topic and what are the recommendations of the experts in that area. And in the US, we have, for example, the US Preventive Services Task Force, which is an independent panel of non-federal experts in prevention and evidence-based medicine, which conducts scientific evidence-based reviews on a broad range of clinical procedures and topics, which also include cancer screening. I want to highlight this because I think this is very interesting. They provide not only recommendations, but they also grade their level of recommendation. A grade A is a kind of recommendation where they recommend a service. There is high certainty that the net benefit is substantial. A recommendation of grade B implies that there is high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial, so they recommend a service. So A and B grading implies recommendation from them. When they do a grade C recommendation, basically they're saying that clinicians may provide this service to selected patients depending on individual circumstances. However, for most individuals without signs or symptoms, there is likely to be only a small benefit from this service. A grading D, the U.S. Preventive Services Task Force recommends against this service. There is moderate or high certainty that the service has no benefit, or that the harms outweigh the benefits. And when you see a letter I, basically they're saying that they conclude that the current evidence is insufficient to assess the balance of benefits and harms of the particular service. And I think we need to be familiar with these kinds of grading systems, because the recommendations are never going to be as easy as yes or no. There's usually going to be a level of recommendation, and then clinicians have to take informed decisions based on that information. And to give a brief example, and with this I'm going to complete my presentation, for example, they recommend biennial screening mammography for women aged 50 to 74 years, and that is a grade B recommendation. For other age groups and other kinds of scenarios, they have other levels of recommendations, which include C, I, and D, which were other examples that I already summarized. And this is not only done in the US. For example, this is you can see later on this information on your slides, but this is also an independent review done in the UK, also for breast cancer, a report jointly commissioned by the Cancer Research UK and the Department of Health of England, which also do an assessment of risks and benefits of current breast cancer screening recommendations. They list some benefits and harms of their current guidelines. And this is a topic that could be covered for a whole day. I just want to highlight other resources. If you look, for example, at the webpage of the National Cancer Institute, there's not only going to be current recommendations in terms of breast cancer screening, but there's also going to be information of other screening methods that are currently under research investigation, and other particular research areas not only being performed in the US, but also through consortiums and collaborative research worldwide. So the overall summary and recommendations of our presentation include that cancer screening may prevent morbidity and mortality. Cancer screening tests are based on assumptions. As we mentioned in our methodology section, we have to be aware of potential biases, because maybe we might be seeing in a research study that a screening test is beneficial, but we want to make sure that it is actually beneficial, and it is not that the way we designed our research study, it was flawed in different ways and actually ended up being biased, and then the results that we are observing are not actually true, but it is the fact that our study was biased, and because of that we cannot actually trust the results that we are seeing. And it's also going to be important to evaluate the screening test through these rigorous trials before widespread community use of these interventions is done, and we have to balance the adverse events and harms versus the benefits. And like I mentioned, it's not going to be as easy as a general recommendation. Probably there's going to be recommendations that are different for particular population subgroups. I want to go ahead and acknowledge Dr. Marcia Cruz, which facilitated a couple of the slides that I used today, and also the organizing committee, the NCI, and the University of Puerto Rico Cancer Center for making this possible. I know this is a lot of information for a short period of time. Most of them is explicitly explained in your slides, but I'll be happy to talk with you later on about these topics, or even in the future serve to you as a resource if I can be of any help for any of the work that you're doing. Thank you.
That was very good, thank you. And I just want to add to something she said about the U.S. Preventive Services Task Force. Not only can we learn from how they grade their recommendations, but they give on their website, which is free and open to any of us, in incredible length, their methodology and their rationale. So whereas some guideline setting are influenced, frankly, by conflicts of interest from the groups that are writing them. And their methodology is not transparent. The U.S. Preventive Services Task Force, I think, is a leader in showing how these should be written and displayed for all to see. So, I think playing off of the previous comments and now trying to plug them directly into news coverage, this is very important. This is my disclaimer slide. I want to be very clear on this, that nothing that I'm about to say is anti-screening. I am not anti-screening. It's interesting, though, that those who even urge a discussion of the benefits and harms of screening are often accused of being anti-screening. So let me repeat again. I am not anti-screening. I do oppose imbalanced, incomplete messages about screening, and I try to improve them. And I say this because I think the last time I gave a talk similar to this, it was at the National Institutes of Health in Washington, and 2 reporters came up and said, "I can't believe how anti-screening you were." And when I asked for evidence of where I was anti-screening, it was questions that I raised about evidence. That's not being anti-screening. So, Dr. Muir Gray of the United Kingdom coined this phrase, which I think is very important, and we just heard a different rendition of this. But he said, all screening programs do harm. Some may do good as well. We never tell the story that way. This is the flip side of what we usually hear. We usually hear early detection leads to a better chance of cure, so screening makes sense for everyone. And remember my scales of justice slide from this morning. Again, in all of our 70% of our 1,900 stories we've reviewed, we see an exaggeration or an emphasis on benefits and an ignoring or minimizing of harms. That is seen nowhere more clearly than in the coverage of screening tests. So here we are again. And this issue that Anna just showed of the U.S. Preventive Services Task Force's recommendations in the fall of 2009 on mammography was maybe the worst example that I've seen. Ooh, this is an outdated slide. I just told you this is my 40th year, so it's not 38 years. It's still the worst example that I've seen. And it's because the task force, I believe it was an I recommendation, wasn't it? Which meant, if you remember her slide, the evidence is insufficient to rule one way or another. So women must know the trade-offs that are involved. So in simply raising the issue of trade-offs, this task force was severely criticized. The editors of this journal referred to it as a media cacophony. The confusion, politics, conflicted experts, anecdote, emotion ruled the news coverage and dinner table conversations. This is what they actually wrote. These are the words they actually wrote. That the decision to start regular biennial screening mammography before the age of 50 should be an individual one and should take into account the woman's context, including her values regarding specific benefits and harms. And yet, this recommendation was criticized as throwing women under the bus, that this was big government showing that it cared nothing about American women. The news coverage of that issue of mammography in the 40s, where it is a less clear issue of benefits than it is in women who are older, is often a matter of an inability or an unwillingness for journalists and the public to grasp or to explain that there can be harm from a simple screening test. Many stories laugh at, almost ridicule, the statements that there can be anxiety from a false positive. Before you would scoff at that or ridicule, I would urge you, talk to a woman who's had a false positive before you laugh at how serious an issue that might be. I've asked many journalists if they've ever spoken with a woman who got a diagnosis of DCIS, which stands for, many don't know what that stands for. It stands for ductal carcinoma in situ. In situ means it is in place. It has not invaded the vessel wall, the ductal wall. It has not become malignant. It may never become malignant. And we're learning more all the time about how many do and how many don't. And the more we do mammograms in younger women, the more this is the leading abnormal finding that result. The number needed to screen that Anna talked about, well, the number of women aged 40 to 49 who need to be screened to save a single life is at least 1,200 and some. Think about that. We have, what, 40, 50 in this room? Think of a room of 1,252, and we'd have to screen all those women in order for one to benefit. Yet the other 1,251 would run a substantial risk, which we'll look at a little bit later, of false positives and other findings that would lead to more testing, some of which carry their own complications, some of them possibly being treated for something that was never going to cause them any harm. And in fact, here are the numbers. Over 10 years of mammograms, 1 out of 2 would be harmed by a false positive. 1 out of 5 would be harmed by an unnecessary surgical procedure. This is a case, and we've seen it many times, of journalists crossing the line from journalistic reporting into advocacy and crusading in an imbalanced manner. This is a woman who is a reporter for CNN, CNN's medical news unit. And this is her Twitter message to all my sisters over 40. I'm sorry, I'm older than most of you, so I come from an old school of journalism, but we didn't talk to people we reported on as our sisters. All right? And she wrote, we need mammograms once a year. Need? Where is the shared decision making? Where is the informed, complete, balanced decision making? We need? This is where we cross a line from independent journalism into advocacy. A physician who saw that Twitter message wrote to me and said, could a political reporter say, vote for Smith? But she's saying, we need mammograms, which in that age group should not be a matter of mandate, it should be a matter of choice. Another case of journalistic advocacy. You'll notice this button is being worn by this woman and by this woman. This woman is a journalist. This woman is the woman she's interviewing, and this woman runs the organization whose logo is represented by this pin. So I'm interviewing her, who runs that organization, and I'm wearing her pin. And from a perspective of evidence-based, she let this woman get away with saying, we've had a conclusion for many years at the Susan G. Komen Foundation that screening saves lives. The 5-year survival rates for breast cancer diagnosed early is 98%, and this is largely due to screening and early diagnosis. We will talk more about 5-year survival rates and how misleading they can be in a moment. Can you imagine, in this case, a political reporter going to work and appearing on TV wearing a button saying, vote for Smith? This is no different, I would say, than what this woman did on a healthcare story. This is what we do, though, and we don't do it maliciously, but we cause harm by this kind of crusading advocacy, which is not representative of all women's experiences and what all women may rationally choose to do. When, and I always forget her name, the NBC reporter, Andrea Mitchell, went on the air, and I'm sorry for her that she was diagnosed and then treated for breast cancer, but I'm happy to hear she's doing all right. She said, screening matters, do it. this disease can be completely curable if you find it at the right time. Many times, what I write about is not what pops into my head, but I happen to be really well connected with the breast cancer community, which is very active on social media. These are not women you want to have on your wrong side. You want to be, and I happen to, for whatever reason, be on their right side. And so one of the most active, this woman who runs a blog called I Hate Breast Cancer blog, wrote, early detection is not a cure. Completely curable is like a fat man wearing a hockey jersey. It covers a lot of ground. So, and the breast cancer community reacted strongly to what they felt was the overstatement of benefit from this reporter in this case. Now, told you this morning I borrowed some slides from Woloshin and Schwartz of Dartmouth. I borrowed these slides because they address this 5-year survival rate figure. This is an ad that the Susan G. Komen Foundation runs. And I got these slides from Woloshin and Schwartz. So they say, the way they read this is conveying to women, don't be an idiot, get screened. In other words, it's not a choice. You're an idiot if you don't do this. It should be a mandate. And there's the figure that they emphasize. 5-year survival rate is 98% when caught early. When it's not caught early, 23%. Well, they're much smarter than I am, and so they help us look more closely at this. Does increased survival rate mean saves lives? They say if we gave an Academy Award for exaggeration, the Academy Award for most misused statistic would be survival statistics and screening. There are 2 ways, we've touched on them earlier today, that you can improve survival without changing mortality. That is the lead time bias that Anna talked about and overdiagnosis. Lead time bias, I was just reading a book on the way here and they referred to this brilliantly. I wish I had a map, but you can bear with me if you know your US geography better than I know my Caribbean geography, okay? So, if you had a train going from Boston to New York to Washington, everyone's going to Washington, okay? One woman got on the train in Boston, another woman got on the train in New York, and the train crashed for both of them in Washington. It would look like the woman who got on the train in Boston lived longer because she got on the train earlier. That's lead time bias. When we find things by earlier screening that do not affect when we're going to die or how we die, but it just looks like we lived longer because of one of the built-in quirks of statistics. You need to know that if you're going to play this game, which is not a game. Yet, that fact does not stop people from misusing survival statistics all the time. Survival is always prolonged by early detection, even when death is not delayed or any lives saved. Improved survival with screening is not evidence that screening works. You need lower mortality to prove screening works. Decreased mortality and a randomized trial is needed to prove screening works and to show by how much it works. So, my formatting might be thrown off again. This is another Macintosh to PC issue, so bear with me. This could be a mess if it gets worse down below. Woloshin and Schwartz have been trying to educate doctors and journalists to explain things more clearly. So they try to break down what happens to 1,000 women who are screened every year or 2 for 10 years. Well, for women 40 to 49, the benefits of screening, the reduced 10-year chance of dying from breast cancer. Without screening, 3.5. With screening, 3. So 0.5 avoided a death because of screening. The harms of screening in that age group, a false alarm that requires a biopsy, 50 to 200 out of 1,000, and overdiagnosis, those who get a diagnosis and treatment for something that never would have caused harm, 1 to 5 out of 1,000. That's a statistical breakdown of benefit versus harm. In the 50-year age group, you can see the numbers are somewhat different. A slightly higher rate of benefit, the harms the same, and the overdiagnosis slightly larger. And in the 60 to 69 year group, the numbers bump up a little bit more. But in this area of contention of the benefit and harms of women in their 40s, the trade-off is rarely explained as simply as it is right here. And you should be given this slide on the USB drive that you'll be given later so that you don't have to furiously write all this down right now. Some of what we see is like crusading. It is not journalistic ethics. It becomes advocacy. It crosses a line beyond what most of us would consider acceptable journalistic ethics. We don't talk about harms. There is a harm behind non-evidence-based promotions. There's a harm in selling sickness. It's like selling the search for weapons of mass destruction inside each of us. And pretty much like the US did in Iraq, it's like, well, if we haven't found it yet, we haven't looked hard enough yet. And it's almost as if we put a guilt trip on the audience. If you haven't found something yet, you haven't looked hard enough yet. Get your screening earlier. That's not an anti-screening message. It is simply an imbalanced way to present this message to people trying to make an informed choice. There is no harm for any of us to admit uncertainty and to educate consumers to understand that it exists. I choose not to run from uncertainty. I would grasp it, embrace it, and attack it. That's why we do research. If we had all the answers, there'd be no need for any of this that we're talking about here today. That's why we do the research. This humorist, an American humorist years ago, uses this phrase that I apply to news coverage of screening. He said, "I honestly believe it's better to know nothing than to know what ain't so." I was talking with journalists during the lunch break, and I honestly believe it would be better not to report on these things than to report with certainty about something that is not certain. You would be better off not reporting than to report what ain't so. Journalist training like this can make a difference. It was after a session like this several years ago in Washington. I was in the session with this woman. I had never met her before. She went home and within days wrote a story where she wrote this, that some early non-invasive breast cancers, and there's that DCIS I told you about, never progress to dangerous cancers. And mammogram may provoke aggressive treatment that ultimately is unnecessary or harmful. She cited her own number needed to screen there to save one woman in that age range. As I said, she had just attended this very similar NIH medicine in the media workshops the previous week, and the training she got there was undoubtedly fresh in her mind. This is an excellent piece that Stephanie Saul wrote on this topic of DCIS in the New York Times. She wrote that diagnosing it is a 30-year history of confusion, difference of opinion, and under and over treatment. You can look up that story yourself if you'd like. This was an excellent story, reporting on a series of articles in the Journal of the National Cancer Institute on DCIS. The issue is important. 25% of all breast cancers diagnosed in the US are DCIS. It can be life-threatening, but most of the time it's a low-grade tumor, best described as something between normal breast tissue and breast cancer. Let me just stop there. How many people knew about DCIS before this today? There are so many questions about this that a consensus conference in the US was held at which it was discussed, should we even stop calling it carcinoma, ductal carcinoma in situ, because that produces anxiety. We might be calling it something that just confuses women. And I wondered, the anxiety they were worried about, is that the same anxiety that some people ridicule and minimize? Just as if you've never talked with a woman who got a false positive and the anxiety she went through, if you've never talked with a woman who got a diagnosis of DCIS, I wouldn't make any judgments until you do so. I have. One year, I interviewed 24 women for an hour each, minimum. And it was one of the most moving experiences. I can remember every one of those women. I can remember how painful it was interviewing them. Dr. Otis Browley, who spoke at the last of these events in Buenos Aires in November, and who is the chief medical officer of the American Cancer Society, wrote, "I think there's a huge amount of confusion about this. I'm more concerned we're scaring a whole host of people that have DCIS who make rash decisions because it's called carcinoma, decisions they wouldn't make if it was more adequately described for what it truly is." So again, I would hold up the mirror and ask you, have you reported on this? If so, how? If you haven't, why not? And when will you? Several years ago, the Sunday Times of London reported on it. This is a rare story. They profiled a 56-year-old woman who said she was not aware of any risks of screening before she had her mammogram. She was diagnosed with DCIS. She now wishes she'd never been screened. Screening has caused me considerable and lasting harm. It has certainly not saved or prolonged my life. The reality of this diagnosis has been 2 wide excisions, 1 partial mutilation, which is what she called it, 1 reconstruction, 5 weeks radiotherapy, chronic infection, 4 bouts of bacterial infection, several general anesthetics, and more than a year off work. That might not be a representative story, but these are among the experiences you need to think about before you write about early mammography. A blog, so it doesn't always have to even be traditional media, in San Francisco reported last year on a woman with DCIS and reported on that woman's choice. Remember this morning I said, talk about alternative options, and instead of always aggressive therapy, talk about watchful waiting. Well, this woman with that diagnosis, and they reported on this, chose watchful waiting or active surveillance rather than immediate aggressive intervention. Some doctors told her she should have both breasts removed, even though there was no evidence that she had invasive cancer in either breast. And this is a common recommendation. This is why my interviews with those 24 women I told you about were some of the most painful I've ever done in my career. This is a terrifically important issue. And this blog reported on this woman going to a shared decision-making program at the University of California in San Francisco, specifically designed to help her understand her trade-offs. And this is one of the leading breast care centers in the US. It was very unusual, it is very unusual to hear these kinds of perspectives in a news story. It shouldn't be if 25% of new diagnoses are DCIS. That's why I say I hold up the mirror. If you haven't reported on this, why not, and when will you? Be wary of precancerous conditions. So DCIS found by a mammogram. One woman told me once that it was, she was told on diagnosis that it was pre-malignant. She said, well, that's like being told you're a little bit pregnant. What she was told was meaningless to her. When you have a pap smear, we always have these acronyms, DCIS, now ASCUS. Does anybody know what ASCUS stands for? Atypical squamous cells of unknown significance. It's the unknown significance that should just be so ironic to women. If it is unknown significance, why are you telling me about this? And yet, do you know, I lose track of the number. A huge number of women are told this from cervical pap smears. Do you know the term incidentalomas? Things we find incidentally that we really didn't need to know about? Is it all really prostate cancer that the PSA blood test finds? Many doctors say that what is found with the PSA blood test is something else. It's like a pseudo-cancer, but it's not the same as other cancers that we know are lethal. And we should remember we are all pre-death. In reporting on the alternatives, colonoscopy may be the gold standard, but whose slide was it this morning? Was it Marcia's slide? And just remember, lower left, the fecal occult blood testing graphic was incredibly low. How much? Less than 10%. Now let me just ask you, I don't know if any of you have a public health degree or training, but from a public health perspective, what is good public health? We try to reach as many people as possible with cost-effective means, right? So which makes more sense? Fecal occult blood tests, which are about $20 a slide. This is a blood stool test, which you can do at home and send it in. About $20, or colonoscopy, which is several $100s, carries some risks. I don't think I would want a perforated colon. And we've never had a randomized clinical trial to prove a mortality benefit from colonoscopy. We actually do have a pretty good trial to show a mortality benefit from the cheaper fecal occult. So think about alternatives. We treat colonoscopy like the sacred cow that we can't touch. And I think we can raise questions about evidence for alternative screening methods. As I said, remember to report on the choice not to be screened, which is a legitimate, smart people can make this choice, and I'll show you some in a moment. Very important. Remember the difference between testing, diagnostic testing, and screening. Screening is like going into a football stadium. This happens to be your football, soccer, but it's in an American football stadium. This was my consensus to the fact that I was not in an American football crowd, okay? I think this is in Seattle Seahawks football stadium, but they have a soccer field out there. Screening is like going into a stadium filled with 60,000 people and you know nothing about them. And you're going to look for problems in presumably healthy people because you know nothing about them. That's screening. That's why there can be harms, because you find things you didn't need to know. This is not a crowd of people with risk factors. So we should not, in my mind, be referring to a woman with a strong family history of breast cancer when she has a mammogram. To me, that's not a screening test. She's in a high-risk group. She has a family history. She's in a high-risk group. Doing follow-up mammography on a woman who's had an abnormality in her breast before is not screening. We are now in a diagnostic mode. We're in a different stage. And if you apply the language of screening to diagnostic testing, you will mislead people badly. Because some people will say, well, my life was saved by screening. That wasn't screening. That was after we already knew you had a problem. Just remember, football stadium, that's screening. You don't know anything about them. They are nameless and faceless, and you're going to test them all. This is the lead time bias. So here is the woman getting on the train in Boston. Here's the woman getting on the train in New York. They both crash and die in Washington, D.C. This one looks like she lived a lot longer because she got on the train that much sooner. So I'm giving you pictures to go home with. The rooster. What does the rooster refer to? Association does not equal causation. The train. Oh, I got a million of them. In prostate cancer screening, this is done widely in the U.S. despite questions about its efficacy. I don't know how widely it's done in your countries. It clearly leads to increased numbers of diagnoses. It clearly misses as much cancer as it finds. It is unclear that it finds disease that is life-threatening but treatable. These are the stories we need to tell. The quandary: there are cancers that do not need to be cured but can be cured. Really important. There are cancers that do not need to be cured. We call them cancers because they can be cured. There are cancers that need to be cured but cannot be cured. And we do not know if we cure any disease that needs to be cured. Do we save lives with this screening? That is an open question. These slides come from Otis Brawley of the Cancer Society. Several studies have shown PSA screening finds a lot of cancer, but have failed to convincingly show that it saves lives. Other good examples of journalism: Sunday Magazine, New York Times, okay? Wide distribution, good journalistic outlet. And a friend of mine, Shannon Brownlee, wrote this article, "Can Cancer Ever Be Ignored?" And in it, she told the kinds of stories that I think we need to look for more often. This is a man at age 47, he's a lawyer, so he's not a dummy. And he was tired, fatigued. He went to see his primary care physician. The doc ordered a blood profile and included the PSA test in the blood profile without telling him. Not informed consent. Indeed, the PSA test was elevated. Very difficult decision making. He didn't want to do anything. His wife questioned him. His co-workers questioned him. He was a lawyer. The law firm, it appeared, may have been ready to drop him or take some of his clients away. He felt the gun was to his head. So he went ahead and got treatment for prostate cancer. And I won't tell the whole story. He has huge regrets. And he says men should be aware of the truly terrible consequences. As a screening tool, you could do as well by throwing dice on the table. Is that an evidence-based approach? These are the stories we could tell. A doctor as a patient, and a top doctor. So this was the head of radiology at Emory University in Atlanta, who published his own story in the journal Radiology. How many of you have heard about virtual colonoscopy? So you don't have to have the scope, but you get scanned. Well, the scan doesn't just look at your colon. It looks at a little bit more, and it found more in him. So he had a virtual colonoscopy. It found something else, something on the kidney, liver, and lungs. Well, you can't stop there. You've got to find out what this is, right? Who wouldn't? I would, once you've started down that path. Well, the kidney and liver problems were benign, but he had to have a liver biopsy. That's not a walk through the park. A PET scan, and more CT scans in order to rule out those problems. But what was going on in the lungs? Well, he had to have major lung surgery, which, I'm sorry, means sawing him open through the ribs in order to find out. And he wrote, "I woke up in the recovery room after 5 hours, chest tube, Foley catheter, subclavian, central venous, nasal oxygen, epidural, arterial, subcutaneously administered heparin, constant infusion of prophylactic antibiotics, patient-controlled analgesia, excruciating pain." And it found nothing, just these incidentalomas. Incidentally, something they found that he didn't need to know about. Total cost, more than $50,000. One man, and a smart man. All precipitated by that screening test of the virtual colonoscopy. We can tell these stories better. So Sharon Begley in Newsweek and her graphics department made that graphic "know," the one word that can save your life, and she profiled a physician at Brown University who says, "I'm not going to have the PSA blood test anymore." And she profiled this woman who is the editor of the prestigious Archives of Internal Medicine, who says, "I'm 50 and I'm not having mammograms anymore." We need to tell these stories more often. Am I out? I am out. Task force, you've already heard about.
I'll give you a few
Okay.
more.
Well, you've already heard about them. They're good. Let's think about who gains from promoting screening. Doctors, hospitals, drug and device companies, advocacy groups. If you can create more worry, you can come up with more funding. Gee, maybe with my website, which is running out of funding, I should get more people to worry. We're trying to get them to relax. In his book, How We Do Harm, Dr. Otis Browley wrote about how hospitals make money off of free PSA blood tests. He came across a hospital marketing guy who was really proud of their business plan. If they screened 1,000 men at a shopping mall, they knew that 135 of them, on average, would come to the hospital to figure out why they had an abnormal test. And they would end up collecting an average of $3,000 a man. This is the business plan behind the screening for prostate cancer. From there, many biopsies would reveal prostate cancer, and nearly all of them would have surgery or radiation. So that hospital was reimbursed at almost $80,000 a person because they did PSA screening in the shopping mall. Browley asked the guy, how many lives will you save if you screen 1,000 men? And the marketing man looked at him as if he were a fool and said, don't you know? Nobody knows if this stuff saves lives. I can't give you an estimate like that. But we do it. We give prizes to suck men in to have PSA blood tests. So this is the Roswell Park Cancer Center in Buffalo, one of our leading cancer centers, where if you can show that you asked your doctor about a PSA blood test, they'll give you hockey tickets or theater tickets. And then in Atlanta, they like that idea, so same thing. If you pledge that you will go in and ask about a PSA blood test, you get Atlanta Hawks basketball tickets. Is that what we should be doing, bribing men with a non-evidence-based approach? The number needed to screen, I gave you breast cancer already. Let's look at prostate cancer. If you screen 10,000 men for 10 years of that age group, 2,400 would get biopsies. You would find 350 cancers. You'd save 7 lives. You'd have to screen 1,400 in order to save a life, and you'd have to screen 50 in order to have 1 life saved. But you have run all of these significant. Having a prostate biopsy is not, again, a walk in the park. The Archives of Internal Medicine wrote, most women with screen-detected breast cancer have not had their life saved by screening. They are instead either diagnosed early with no effect on their mortality, or they are overdiagnosed. Quickly, this is a site you can visit on your own. It will help you with the number needed to treat, the number needed to harm, or the number needed to screen. And it's simply the NNT, which stands for number needed to treat.com. It's a very simple site. Graphics are not very elaborate. Go there. It's a very helpful resource. This is an example of how they break down CT scanning for lung cancer screening in high-risk smokers. So up here they're saying you'd have to screen 217 in order to save 1 death. For those who got a CT scan, almost no one got a benefit. Almost no one was helped. 23% were harmed by a false positive. 3.5% harmed by having more surgery. 0.6% harmed by having a complication of surgery. In other words, and we can explain things this simply. 1 in 217 were helped. 1 in 4 were harmed by false positive CT scans. 1 in 30 harmed by unnecessary surgery. 1 in 161 harmed by surgical complication. Then we can ask smokers to think about, which one do you want to be? Do you want to roll the dice? This would be an informed decision. But journalists and we in the public don't handle uncertainty very well. We demand answers that are black and white when the evidence is very gray. There's a problem with our stories when we convey certainty where certainty does not exist. Journalists could help people understand and deal with the clash between science and intuition, between evidence and emotion, between data and anecdote. The plural of anecdote is not data. Between recommendations for the entire population and decision-making by an individual. The difference between what we can prove and what we believe, what we wish, or what we hope. Anna, you used Dr. Brawley's line. We need to communicate to people what we know, what we don't know, and what we simply believe. We could help people understand the difference between grasping uncertainty and helping citizens apply critical thinking to decision-making issues. The difference between that and promoting false certainty and non-evidence-based cheerleading advocacy. This is Otis Brawley. That's that quote that Anna and I both used. I want to acknowledge I took some of these slides from Dr. Brawley, from Ivan Oransky, and from Steve Woloshin and Lisa Schwartz. Thank you for your interest in this. Hope we haven't overwhelmed you with all this screening stuff.